I think one of the myths that Indonesian parents or maybe Asian parents have is that if you put like baby pampers to children, they will like walk really weirdly. Is it a myth or is it true? Hi everyone, welcome back again to Medifly podcast. Today I'm still in Subang Jaya Medical Centre if you've been watching our episodes, but I'm with a different doctor. Right now I'm with Dr. Roshan Gunalan. So Dr. Roshan is a consultant orthopedic surgeon here at Subang Jaya Medical Centre. Thank you very much, doctor, for agreeing to be in this podcast. Will it be okay if you say hi and like introduce a bit? Because I see that you have a lot of qualifications as well, and I'm scared I might be pronouncing it wrong.
No problem. Okay, so I'm Dr. Roshan Gunalan. I work in Subang Jaya Medical Centre as a consultant orthopedic surgeon. My main specialty is dealing with pediatric orthopedics, which means children with any bone or joint problems, as well as limb deformities, and as well as general trauma and injuries and fractures.
So I did a bit of a research, doctor, about your background and all that. You went to Dublin and then you come back to Malaysia, is it?
That's right, yeah. So I did my undergraduate degree in Dublin. So after I completed that, then I moved back to work in Malaysia in my early days as a doctor.
What made you choose pediatry though, doctor? Because I think the bones of the children are a bit more sensitive,
Yeah.
right?
So the thing is, this is in general, we do orthopedics first, and then you subspecialize into different fields. So orthopedic in Malaysia has actually 9 different subspecialties, to be honest. So there are 9 different fields in which people go, from those who do joint replacements, spine surgery, tumors, hand and microsurgery. So the one that I do is pediatrics, as well as limb lengthening and deformity surgeries, right? So basically it is a bit more of a niche area compared to the more general joint replacements and all that. And why I got into it is generally I started working in University Malaya in 2011, and from there I was in the unit together with Professor Soek, who's quite famous in Malaysia for these conditions, for pediatric orthopedic. And I think at the early days he already sort of guided me towards pediatric orthopedics, although it's not a very lucrative or big specialty. I think in Malaysia we maybe have about 25 to 30 pediatric orthopedic surgeons who are actually qualified in that sense. So I think it's early stage he guided me, and he actually took me even overseas to introduce to other sort of specialists in the same field. And so I became known that I was doing pediatric orthopedics quite early actually in my training. And then I just stuck onto that, yeah.
After doing it for so long, doctor, what are the most common pediatry orthopedic problems that you saw happening?
So it varies quite a lot, because you see a wide age of people, a wide range of patients, and the very young present differently. The older kids have different issues, but majority you see are those with limb problems. That means they walk a little weird, or the position of their limbs are not correct, or they come in with pain and infections as such. So the common ones are generally related to their gait or their walking style or their walking pattern, or an obvious deformity.
What about bow legs and like knock knees?
Yeah, so that is one of the common things that we see, the bow legs and knock knees. So this is a very important point in pediatric orthopedics. So bow leg and knock knees have a very, very large physiological component. Physiological meaning that it is normal and it changes over time. Okay, so the bone of a child, when they are born and during the first 2 to 2.5 years, they are generally a bit bowed. When they get a bit older, when they're 3 to 4, they go in the opposite direction. They go in an X shape. They go into what they call a valgus knee, and they reach the adult alignment only when they are about 8 to 10 years old. Okay, so this is a physiologically normal child. So they go and it changes as they grow. So obviously a lot of parents are concerned that the child is not walking straight or it looks weird, and so they do come in, and the aim is to differentiate between what is known as this physiological variant with another component, which is the pathological variant. So the pathological variant is maybe only in about 5% of the children. 95% are physiological. So in that 5%, they do not follow this pattern. If they're bowleg, their bowing actually gets worse as they get older. It tends to curve more. And then they end up, walking even more, getting knee pain, falling, and that kind of symptoms come in. So the aim is to assess them and differentiate whether it's a physiological or a pathological type. Physiological, you let them grow up and you monitor as they grow. Pathological, there are various options to treat it.
You mentioned earlier that it's because of other factors as well, right, doctor? There's a physiological and pathological and all that. I think one of the myths that Indonesian parents or maybe Asian parents have is that if you put baby Pampers to children, they will walk really weirdly. Is it a myth or is it true?
Yeah, it's probably a myth.
Oh, it's probably
yeah. So Pampers wearing and carrying and swaddling and all that, for bow legs and for knock knees, it actually does not play a part. This is generally the shape of the bone. So whatever you wrap around the child and whatever you wear for him, whatever shoes you wear for him, if the shape is curved, the leg is going to be curved. Because foundation is the bone. If the bone itself is curved, whatever you wear on top doesn't make a difference. So generally that's what happens. Yeah?
At one point would we know, or parents know, okay, so this is physiological?
That's a very good question. When it comes to bow leg and knock knees, right, as it is one of the big topics in pediatric orthopedics, the timing of any intervention is very, very important. Okay, so some parents come and say, I want it done early so that when he grows up things are better and all that, but that's not the right thing to do in this case. So because there's a variant, generally the only treatment, the correct treatment age is usually 2 to 3 years, in that range. If you treat too early a bow leg, they end up going in the opposite direction. If you treat it too late, it's a bit more difficult. So it's very time specific, the treatment for bow legs and knock knees, based on the age of the child and based on what type of disease it is basically.
But I think it also depends on the development of the children, right, doctor? Say, for example, some kids can walk within 10 months, some kids can walk after 18 months and all that.
So development plays a part. Those who tend to walk a little bit earlier, actually, tend to develop a bit more bow leg initially, because they start putting weight on the immature bone a little bit earlier.
Okay, so but is it actually painful, doctor, for the children too?
Most of the time, no. So bow leg and knock knees are generally painless conditions. It's just the way that they stand, the way that they walk, and their movement is a little abnormal. But majority of them are fully functional.
Okay.
They can actually run, jump, climb, everything, even with the position of the leg like that.
So we just talked about bow legs and all that, but what about flat feet, doctor? I think that's also one of the most common.
Yeah, so flat feet is actually one of the most common patients I get actually in clinic as an outpatient. So flat feet is another sort of a common condition that again is divided into two. So you have the physiological or flexible and you have the pathological. And again, majority are physiological. Okay, so the arch of the foot, right, technically does not develop fully until the age of 7 or 8.
Okay.
So if someone comes at 1 year old and says they are flat foot, generally, they do have, but it's because they haven't developed as yet. Okay, and the second thing is majority are what they call a flexible flat foot. So flexible flat foot just means that inside the bones and the joints, everything is normal. But what is supposed to give it the support and give it the shape, that muscle is a little weak, a little lazy. So when they stand, they go into a flat foot position. And these children, when they tiptoe, they actually will see that the arch reconstitutes itself. It develops again. So it's a physiological or flexible flat foot. Flexible flat foot, which is painless, does not require too much treatment. Okay, you just need some exercises to strengthen the muscle, and that's it. And the arch eventually develops a little bit. Flexible flat foot that is painful, which can happen sometimes, will need treatment. Okay, so any condition that's painful will need treatment. Yeah, so that is the second category of it. And the third category is the purely pathological flat foot, where it is not flexible, it's rigid, they call it. So the rigid flat foot generally will need some sort of treatment.
Where do the pain lies, doctor? Because I have a bit of a flat foot, and the pain is on the bum. Yeah, the bum of the foot.
That also varies, okay? Because the foot is a very, very complex structure. There are many small joints inside, there are many small ligaments inside. And when the balance of your leg is off and you are very active and you move, some of the joints tend to wear out faster, they tend to complain a little more because you're not walking properly. So the pain generally can happen at the foot itself, at the top of the foot sometimes, and even at the leg. Sometimes children get leg pain because the wheels are not balanced basically, so the pain is a little elsewhere. But it can even up to knee pain sometimes. They present with knee pain, but actually it's because they have a rigid flat foot or the base is not stable.
I'm not sure if this is common as well, but back then when I was a kid, I remember that even if I walked straight, I could all of a sudden fall without any obstacles or anything. So I'm not sure if it's because of the flat foot. And I think one of the doctors mentioned my bone density is very, very low.
Okay, so it depends. So each individual will be different. You could have been just clumsy as a child, and why you were falling all the time. Because flat foot generally doesn't cause someone to fall. Alignment, yes, rotational alignments can, especially in the very younger children. If you have a condition called hypermobility, hyperlaxity, which you may have or may have had, that actually does contribute to children falling a little more often than they should. They tend to be a little bit more clumsy, they tend to have a bit of flat foot, and sometimes they tend to have very non-specific pains here and there, especially during the younger 6 to 10 years old age group. They tend to come back with very non-specific pain. So they have a condition called hypermobility. So it's not necessarily due to the flat foot.
What about the foot that goes like this? Is it club
Inwards,
foot?
yeah, club foot.
Is that also common?
It's not a common condition, but I see it commonly because I do these things. So for me it's common, but in the population it's not. So 1 in 1,000 almost.
But what causes that, doctor?
So club foot has a genetic component to it. There is a genetic component to it, and there are various hypotheses as to why it happens, most of which is in utero, during the development of the child. During the development of the muscles and the bones and the joints, something goes wrong. So when you have a lot of hypotheses as why it happens, actually we don't know, basically. There are too many theories more than the actual facts. So why it happens, there is a genetic component and it's a contribution of multiple factors. Yeah.
If someone has a club foot, what do you treat it with? I heard there's like Ponseti.
Correct, yeah. So again, club foot, we go back to the same thing. You have a physiological variant as well. Okay? So you have a club foot which is called positional or physiological. That is usually a normal child with a normal foot in a very tight uterus. So their position is inwards. So when they are born, they look like they have a club foot. But when you assess them, when you check, you notice that the foot is very supple, very flexible. So that is known as a positional or flexible club foot. Does not need any treatment, just some stretching exercises. As the child grows, the foot comes back into a normal position automatically. But the majority of that I see will be the rigid type of foot, which is the pathological type. So that, yes, that requires treatment. And currently in Malaysia and in general worldwide, a lot of countries, some European countries no, but they do this Ponseti method of treatment, which is a specialized, treatment protocol for club foot. Yeah, so do you want me to explain it?
Yes.
So basically, Ponseti's method works on the principle that if you stretch a muscle and maintain that stretch for a period of time, it will lengthen. The tendons lengthen. So what we do is we do serial casting, as they call it. We apply a cast for the child. And then every week we change the cast and manipulate the foot into a better position. So it takes about 5 to 6 change of cast, 5 to 6 weeks before the position of the foot gradually gets back into position. So we are stretching each time we put the cast, we are stretching the leg and we are maintaining that stretch with the cast. Yeah, and that happens for a period of 5 to 6 weeks. After which they actually go on this type of special orthosis. So these shoes are, they call it foot abduction orthosis. Yeah, and this is to maintain the correction of the foot that we have achieved. Okay. In between, once you've done the casting, sometimes you do a small procedure to lengthen the tendon at the back, and then you go on to the shoe as well. So that is the general protocol for Ponseti treatment, and it's very, very good success rate. If the child is treated a little bit early, if you catch them early, it's better prognosis, more predictable outcome. And second is if they are compliant with the treatment. Because this is not a come today, cure tomorrow condition. They are with you for 5 to 6 weeks. Every week they have to come, change the cast. It's not an easy process because the child is crying, the mother is angry, all sorts of things happen, yeah? And then once they're off the cast, they have to be on this shoe. So although, as you say, it looks kind of cute, there's no child that is actually happy to wear this. I've never had a baby who was very happy and satisfied once they put this on. they find it very uncomfortable and they start crying and crying and crying. And then the compliance of the parents reduces because the child is crying.
Okay.
So once you stop using this, the clubfoot recurs. It comes back. It starts to bend inwards again. And then we start back the whole process of treating and casting. So that's the biggest drawback is you need good compliance. And you need the parents to understand that the children don't like it, but eventually they get used to it. So you have to push through the initial phase and make sure they use it. Because you use this until they are about 4 to 5 years old.
It's pretty long then.
A very long time. So your process of treatment is not a quick one.
But after 4 to 5 years old, they can take it off and they're fine, right, doctor?
So there is a sort of a period, a protocol for the bracing as well. So you use it for 23 hours a day for the first 3 months. 23 hours a day. 1 hour is just for you to shower, bathe, whatever, free time. After the first 3 months, you generally use it only when the child sleeps. So nap time. So generally they're free throughout the day. When they're sleeping, you put it on. And that goes on until they're about 4 to 5 years old. Yeah. So it's a long process. And
23 hours sounds like a...
Yeah. Well, when they're young, when they're like less than, they're 6 weeks old, 2 months old, they're quite okay with it,
I think we just covered like quite most of the common ones. I think there's one that's missing, which is like hip displasia.
Displasia,
Yeah.
okay.
Is that also something?
Yeah. So again, it's not super common in general population, but it does happen. Hip dysplasia is a bit more complex. Okay. So hip dysplasia is a spectrum of disorders, right? Okay. It can be as mild as when the baby is born, you hear a small click in the hip, a little bit of click, but nothing else wrong. Okay. It's as mild as that to a severely dislocated hip that cannot move, and it happens at birth. That means not at birth, it's happened before, but you diagnose it at birth. So these hip dysplasias usually are picked up early. Most of the time picked up early because every child that is born has a screening done by the pediatrician to check for hip dysplasia. Problem is sometimes there's a bit of error in the screening. It's a clinical test. Okay. So depending how accurate you test it and all, there is a variant in how specific as it can be. So if they're caught early, if we catch the condition early, treatment is a little simpler. Okay, so hip dysplasia, as I said, is a spectrum. Goes from just a minor clicks in the hip to a severely dislocated hip. But majority that we see will be in between. Okay, which means they are unstable hips. So unstable hip is a ball and socket joint. Okay, moving around. What is hip dysplasia is the socket is flat. Okay, it's not very round, and the head, which is supposed to be round, is also not very round, it's a bit flat. So it sort of slips off easily. So sometimes they're born like that, and as they move it, it goes in and out. So it's an unstable hip. Okay, and treatment, although it varies depending on age, in a younger child, 0 to 6 months maybe, you put them on what is known as a pelvic harness, which is basically like a brace, and then it holds the leg in position. Or we put them on double pampers, again to keep the leg in a certain position so the hip is stable. Yeah, as they get older, then you need to use things like cement casts, spica casts. As they get older, then surgery is involved. Yeah, but all of this treatment has only one aim. Okay, the aim is actually to bring your ball and socket together. That is actually the aim. When you're younger, it's just by position. Position like that. As the child grows, it actually forms back. It actually shapes into a proper shape. So you need contact between the femoral head and the acetabulum, or the ball and the socket have to be in contact. No contact, there's no remodeling, there's no healing. If there's contact, the child grows, it heals. Okay, but the way we do it varies with age. So younger is less invasive, obviously just splints and whatnot. Older, you need a cement cast to hold it in position. Even older, you need surgery where you actually need to divide the bone and realign everything and put wires and plates and screws and all, and it gets more complex. As the child gets even older, it's even more complex. But all of them aim for the same thing, bring it into position.
You mentioned about birth earlier, right, doctor? Yeah. And as a child, I was told that I have a supple bone, so I can keep on doing this. So there's a lot of bone problem in my body actually. But how far is it that it draws back to when the mother is like having the baby? Do they have to like drink calcium and all that? Like how far does it go back?
I think you don't actually have a bone disease, so it doesn't play a part. It's just weird. But in terms of nutrition and whatnot, it does play a part. If you are malnourished or you have deficiency in certain things, there can be a child with bone issues. But majority of bone diseases in children are either metabolic in cause or congenital. So which means that even if you're well nutrition, eating healthy, you have nothing wrong with you, super healthy, the child still can have a genetic component which causes them to have like a brittle bone or a hip dysplasia. So can't really say it's because of that.
So, but if they're like, I think this is my last question as well, and probably what the parents want to know as well. If there are any one advice you can actually give to parents to know more about the bone or anything relating to orthopedy about their children, what would it be, Doctor?
Okay, so pediatric orthopedic is a niche sort of specialty. Okay, very few people do it, very few people understand it, and children are not just small adults. Okay, the pathologies that we see, the conditions that we see are different from what we see in adults. The way their response to treatment is different from adults. And even injuries, if they have fractures and broken bones and all that, the way we treat and the way they heal is different from adults. So there's a variation in adults and children in terms of that, in their bone health, I would say. Second is the child is very dynamic. The child is growing, whereas adult doesn't. So a lot of things are very time specific in terms of treatment. Things like clubfoot and DDH, like dysplasia of the hip, see them early, treat them early, then it's good prognosis, more predictable outcome. Things like bow leg, knock knees, flat foot, time specific treatment. So you see them early also, you have to treat them at a specific age. You cannot simply treat everyone early and say it's all good. So that's very time specific. So there are certain conditions which are time specific, certain conditions that need to be treated early. So that is a variation in terms of the different diseases that we have that needs to be treated. But most of the time, if there's any sort of abnormal walking or limping, in a child that you notice, it is best to get them seen and assessed. Majority of the time, it may be what we call the physiological variant again. You may not need any treatment, you just need some reassurance, some follow-up and whatnot. But if we miss that few percentage, it actually gets a lot more difficult to treat as the child grows. And as an adult, it may lead to further complications. Like hip dysplasia, for example, a lot of times we see patients with a missed hip dysplasia. So they come to you maybe when they've started walking only, after 1 year plus. Then nobody noticed at birth. Of course, the child was not walking, but when they start walking, they're walking funny, and then you realize they have a hip dysplasia. You notice one leg is shorter or something. Some of them, even worse, even with that, they grow up and they come to you and they're 9 years old or 10 years old. In which case, they've been walking funny, but nobody really bothered. Or maybe it's bilateral, that means both hips are out. So there's kind of symmetrical, but they're just walking with a waddling, swaying sort of gait, so nobody really notices.
Pretty sure it's going to hurt so much.
It does not hurt. A dysplastic hip does not hurt actually. Yeah, some people are even adults, and maybe we missed it anyway. Yeah, so yeah, it's a weird condition, but it's generally painless. It doesn't cause too much pain in the early stage. As an adult, as an old person, then you start to develop a lot of other problems, which is why it's treated earlier, basically.
Okay. So I think for everyone, I think it's probably a bit hard for parents to, because the child cannot actually tell them that they're having this and having that, right? So I think for parents who kind of identify weird things about the structure, the way of walking and all that, it's probably better to just
get it checked out, So a lot of times when you see the child is walking funny, it will not really be the parents who would notice, but there will be some auntie or some grandmother who says that, something's not right, and that's when they mostly come in. So generally due to that, most of the time, you won't notice your own child walking weird. And again, it's just good to see it early so that certain things you can treat when needed. But things like clubfoot are very obvious at birth. You cannot miss it. If it's a clubfoot, it's staring you in the face. And that generally needs to be treated early. And there are very few centers, I would say, that actually do clubfoot treatment using this Ponseti method. And this is one of the places that I do. So I've had a few patients, even in the private center, as follow-up. When I was in the university, we did a lot more, obviously. It's a government service, so you get a lot of referrals, patients from elsewhere.
Thank you very much, Doctor. As a child with quite a lot of bone issues, I understand how it feels because, but thank you very much, Doctor, for agreeing to being featured in the podcast. For everyone who wants to talk more and know more about Dr. Roshan's work. Dr. Roshan's is in Subang Jaya Medical Centre. You can check it out through our website as well. It will talk more about Dr. Roshan as well. If you have any more questions, you can leave it out in the comments. And hopefully in a month or so, I can come back and answer all the questions that you have about Dr. Roshan and his work and all that. But thank you very much for watching this podcast. Thank you again,
Thank you so
Dr.
much.
Roshan.
My pleasure. Thank you.
Thank you. Don't forget to like, comment, and subscribe.